Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Joining me for this Platinum Lecture is Dr. Emmanuel Antonarakis. He is a professor of Oncology and Urology at the Johns Hopkins Sidney Kimmel Cancer Center in Baltimore, Maryland. Emmanuel is going to cover a very contemporary topic, and that's castrate-resistant prostate cancer. And he's going to focus on the developments and challenges that occurred in this last year, 2020. Emmanuel, thanks for joining us.
Thank you, Dr. Crawford, for the kind invitation to come and speak with you again. As I was reflecting on the past year, 2020, I will not comment on the political situation, but I was reflecting on some of the advances that we've made in castration-resistant prostate cancer. And I really wanted to focus on this lecture on one of the great successes of 2020, but also to talk about one of the challenges, which has been the lack of approved PD-1 immunotherapies. So this will be the outline of my brief talk for today. Start off with the treatment landscape for mCRPC, talk about one example of a great success, one example of a challenge, and then conclude with my vision of where the molecular classification of CRPC is taking us in the future, and I would argue that the future is here. So this is a rendition of Howard Scher's famous clinical states model that we're all familiar with. On the far right, what I'm emphasizing here are the FDA-approved systemic therapies for metastatic castration-resistant prostate cancer. The 6 on the bottom are the ones that were approved prior to 2020, and the 2 at the top with the red blast are the PARP inhibitors, which have now been approved for these homologous recombination gene mutations, and we'll talk about that in a second, what that means. And then we have this rare indication of pembrolizumab, the PD-1 inhibitor, but only for those patients that have the mismatch repair deficiency, also called MSI high phenotype. And I'll talk about that, and I'll raise some of the challenges for PARP inhibition, for a PD-1 inhibition development in prostate cancer. So first, let's start with the strengths and with the successes. Many people have heard about this new class of drugs called PARP inhibitors. And I just want to start by reviewing the 2 FDA approvals, and then I'll work backwards and talk about the data that led to the approvals. So these drugs are approved for a special type of prostate cancer that has mutations in a type of DNA repair gene, which is called the homologous recombination repair, HRR for short. There were 2 drugs. Both of them were approved serendipitously 5 days apart back in May of 2020. The first was olaparib, and this drug was approved for a panel of 1 of 14 HRR mutations. And the second is recaprib, which was approved the same month, 5 days earlier, which is approved for a more narrow indication only for the BRCA1 and BRCA2 mutations. So a little bit more restrictive for olaparib compared to recaprib. Both of these are oral agents, and we'll talk about each one in turn. Before we do that, I really wanted to emphasize the importance of these so-called homologous recombination repair genes and discuss their prevalence. So on the left, I'm showing the prevalence of these HRR genes in metastatic castration-resistant prostate cancer. And the rule of thumb that you can remember easily is about 25%. So about 1 in 4 metastatic castration-resistant prostate cancers, if you sequence the tumor itself, will have one of these mutations, BRCA2 being the most common, followed by ATM, followed by BRCA1, and then followed by a number of other rare genes. On the right, I'm showing the germline mutations, the inherited mutations that are found in these patients. And here, the number to remember is 12%, which is roughly 1 in 8 men. And of course, these are inherited mutations. They come from a parent. And again, it's the same genes popping up again and again, BRCA2 being the most common, followed by ATM, followed by CHEK2 and BRCA1. Now, either a germline mutation in these genes or a somatic mutation is enough for the eligibility of PARP inhibitors. It doesn't have to be germline. It doesn't have to be somatic. It can be either one. And these drugs, PARP inhibitors, PARP stands for poly-ADP ribose polymerase. It's a jargon term. It basically, these drugs work for men or for cancers that have a deficiency in the homologous recombination repair. This is the pathway that fixes double-strand DNA damage. Every time a cell replicates, it has to, of course, replicate its DNA first. During that replication process, errors can occur. And those errors can either occur in one strand, those are called single-strand breaks, or they can occur in both strands at the same time. Those are called double-strand breaks. There are two main processes that fix these double-strand and single-strand breaks, respectively. The double-strand breaks are primarily fixed by these HRR proteins, the most important of which is BRCA2, and the single-strand breaks are fixed by this enzyme called PARP1. And just like many things in nature, there's a redundancy built in, meaning that if the double-strand repair mechanism is crippled, the single-strand repair mechanism can take over and that cell can survive. Similarly, if the single-strand repair mechanism is crippled, the double-strand repair mechanism takes over and that cell survives. Synthetic lethality is a situation where both the single-strand and the double-strand DNA repair pathways are both crippled. In the case of PARP inhibitors, the drug cripples the single-strand repair pathway, and the gene mutation, which is present in the tumor, for example, BRCA2, cripples the double-strand pathway. And that is shown on the cell on the far right, where you can see that a drug inhibition of PARP in the context of an existing BRCA1 or BRCA2 mutation leads to catastrophic DNA damage that accumulates in the cancer cell, leading to cell death. Enough about the theory. Let's talk about the pivotal trials. The first time that we all heard about olaparib was in 2015, when Joaquin Mateo and Johan de Bono published this very small paper, but meaningful, in 49 patients. And what we saw for the first time was that patients that had one of these gene mutations shown on the table, most commonly BRCA2, had a much better response to this class of drugs than patients who didn't have one of these mutations. There was then a second trial called the TOPARP-B, where the authors more carefully looked at individual genes, BRCA1 and 2 compared to ATM, compared to PALB2, compared to CDK12. And the bottom line from this table, which is a little bit busy, is that this drug works the best against the BRCA2 mutation, has an intermediate efficacy in ATM and PALB2, and has a lower efficacy against some of the other genes. So perhaps a BRCA2 predominant mechanism of action. This led to the phase 3 trial, which was called PROfound. This was a randomized study. This study was only for patients with a germline or a somatic mutation in one of the 14 HRR genes. Cohort A was focusing on the 3 primary genes of interest, which were BRCA1, BRCA2, or ATM, and cohort B was the other 12 genes. And in each cohort, there was a randomization between the olaparib or the physician's choice. Physician's choice basically was either enzalutamide or abiraterone, and these were all patients with mCRPC who had received at least one or both of the novel androgen-directed therapies. They were also allowed to have up to 1 taxane chemotherapy, although a taxane chemotherapy was not mandated. This shows the top-line results published in New England Journal of Medicine. The primary endpoint was radiographic progression-free survival. Secondary endpoint was overall survival. Here, what I'm showing is the entire combination of patients consisting of cohorts A plus B. So every patient in the entire study that enrolled, irrespective of what gene mutation they had. They all had to have a gene mutation, but one of the 15 genes. And as you can see here, the blue curve is the olaparib, the red curve is the physician's choice standard of care. Both of these endpoints were met, and the FDA approved the drug. Interestingly enough, and surprisingly to me and to others, the FDA approved this drug olaparib for all 14 genes, not just BRCA1, BRCA2, and ATM. However, when you look into the supplemental material, and this was kind of buried deep in one of the last pages of the supplement, what I'm showing here is the radiographic progression-free survival on the left and the overall survival on the right, comparing the olaparib versus the control group according to the exact gene mutation. And this chart, in my opinion, is very informative because it shows that for BRCA2, which is shown across the top, the benefit of olaparib compared to control is very, very significant. for example, 10 months of PFS versus 3 months, and 28 months of overall survival versus 15 months. However, when your eyes scan down the list and you start looking at CDK12 or ATM, or frankly, even BRCA1, you see that the PFS and OS comparing olaparib versus the control arm doesn't seem to be that different anymore. My conclusion from this, and you may call me cynical, is that the majority of the benefit was driven by BRCA2, and the BRCA2 patients carried the day, so to speak, and made the entire trial positive. And because the trial was positive as designed, the FDA chose to approve this drug for all of the 14 genes. My editorial comment is that, yes, it's always good to have options for all of these patients, but we also want to offer this primarily to those patients that have the greatest chance of benefit. And in my opinion, that's the BRCA2 folks. Now there's a second one, recaprib. This was based on the Triton-2 and Triton-3 studies. The Triton-3 is the phase 3 trial, which is ongoing. The Triton-2 was the phase 2 single-arm study, which somewhat unexpectedly led to an FDA approval. And I say unexpected because it's the first time in the history of FDA approvals that it was done with a non-randomized trial, number one. And number two, it was done with an objective response endpoint, not a overall survival or PFS endpoint. Now, the approval is contingent upon a positive phase 3 study. So it's called an accelerated approval. It's not a full approval, but yet the drug is now approved and on the market. This was the design of the Triton-2 study, non-randomized trial, single arm. Patients had to have one of those HRR genes shown in the white box on the bottom left. They were then given single agent recaprib orally, in addition to ongoing castration, and the objective response rate and the PSA response rate were the two primary endpoints. This shows the objective response rate amongst those patients who had measurable disease. At the bottom, I'm showing a waterfall plot of objective response for those patients that had BRCA1 or BRCA2 alterations. And as you can see, about 40 to 45% of them had a RECIST-defined objective response, which is frankly quite impressive. However, if you look at the table above and you start to comb through the ATM gene, the CDK12 gene, the CHEK2 gene, the objective response rates in the non-BRCA genes were very, very close to zero. And so much, much less impressive in my opinion. And this is mimicked with the PSA 50 response rate. The bottom blue waterfall plot shows the PSA responses in BRCA1 and BRCA2. Once again, more than half of patients had a confirmed 50% PSA response. But then again, when you look at the table and you break it down, comparing against ATM, CDK12, and CHEK2, PSA responses much, much less impressive in the single digit percentage range for the other genes. This is the ongoing study that is required by the FDA in order to gain full approval of recaprib. This study is randomized and does have a control arm. The control arm is also physician's choice, this time including Abi or Enza or a taxane chemotherapy such as docetaxel. And this study is focusing only on the three key genes of interest, BRCA1, BRCA2, and ATM, and is excluding the other genes. There's two other PARP inhibitors. One is called niraparib and one is called talazoparib, and these have shown similar results. Most of the benefit is in the BRCA1 and BRCA2 patients, as shown in the blue waterfall plots here, and less impressive in the orange, which is the non-BRCA. And similar pattern with talazoparib. Again, the dark blue and light blue bars here show PSA responses and RECIST responses in the BRCA patients, and then the other colors, the red, the orange, are the non-BRCA genes. So again, most of the activity appears to be confined to or predominantly in the BRCA1 and 2 genes. One thing that interested me when I saw these data was whether the BRCA1 and BRCA2 genes should be lumped together just because they sound similar, or whether they might actually have different prognostic implications in the context of PARP inhibitors. And Dr. Murkowski, who's a junior faculty at Johns Hopkins, and myself wrote this editorial with a meta-analysis where we took all the published data from the pivotal trials and we specifically honed in on the BRCA1 patients and compared them to the BRCA2. And the reason we did this was because in all the publications, those two genes were basically grouped together as one monolithic unit, and we wanted to look at the individual contribution. And surprisingly to us, and I've highlighted that in red underline and green underline, all the clinical outcomes were inferior with PARP inhibitors in the BRCA1 patients compared to the BRCA2 patients. It was at least half the efficacy with respect to PSA, objective response, and PFS. So this even further led me to believe that perhaps not even BRCA1 should be lumped together, and maybe, you know, the king here is BRCA2, and all the other genes are sort of riding on the success of BRCA2. It's my personal belief. So my conclusion on the first part of the talk is that we now have two PARP inhibitors. It is exciting. Would I call it a breakthrough? I think it's a breakthrough, but probably for those patients with the BRCA2 mutations. In the BRCA1 mutations, less significant activity. In the other genes, we just don't know yet. There's limited activity, or there's not enough information. And obviously the next step is to try to do better than this. You know, a 50% response rate in BRCA2 still means that half of patients with BRCA2 do not respond to a PARP inhibitor. So what other drugs could be combined? And that will be the subject of another talk. But we've also had challenges in 2020. And one of the ongoing challenges has been the lack of FDA approval of a PARP of a PD-1 inhibitor. If you look at the website for pembrolizumab or the website for nivolumab, there's about 12 cancer types that these PD-1 agents respectively have become approved for. And prostate cancer is the one glaring omission on both of those websites and both of those drugs. And it's really been a struggle to get these drugs to be successful in prostate cancer. This was the first study that was conducted with pembrolizumab in a large-scale fashion. It was 260 patients with metastatic CRPC who had received at least one prior AR-targeted therapy plus one taxane chemotherapy. And on the left, I'm showing the objective response rate, very sobering and very modest, I would say, with only a 5% objective response rate. Nobody would get excited about that. Clearly, there are patients who benefit, but it's the minority. And on the right, PSA response rates, which are typically at least double what you see with the ORR, in this case was only marginally higher. So both objective response and PSA response quite low when you use PD-1 agents in unselected patients. Now, when you combine a PD-1 inhibitor with a CTLA-4 inhibitor, in this case it was an ipilimumab plus nivolumab, you do slightly increase the efficacy, about a 15 to 18% objective response rate with about a 14% PSA response rate, but this comes at a much higher toxicity. And with this combination, more than 50% of patients developed a grade 3 or grade 4 immune-related toxicity, which can be very serious, sometimes can be life-threatening, and sometimes leads to endocrine dysfunctions, including, for example, adrenal dysfunction, pituitary dysfunction, thyroid dysfunction, which may be irreversible, in addition to, of course, autoimmune diarrhea, autoimmune colitis, autoimmune pneumonitis. So most people would agree that the combination of IPI plus Nivo, even though it marginally improves the efficacy, comes at a great cost of toxicity. We were all excited a couple of years ago when the FDA approved pembrolizumab for any cancer that has an MSI high phenotype or a mismatch repair deficiency. These are the cancers that develop hundreds and thousands of mutations because they are lacking or they have a deficiency in one of the 4 mismatch repair genes whose job it is to fix these DNA mismatches. And when those genes are impaired, the cancer genome develops hundreds and thousands of these mismatches over time. Unfortunately, once again, the prevalence of these mutations, we're talking here not about the BRCA1 and BRCA2, but about the MMR mutations, is very, very low in prostate cancer, approximately 2.5%. This was one of the first studies. And then there was a second one from Memorial Sloan Kettering, where they did tumor sequencing on about 1,000 consecutive prostate cancers, and they found a prevalence of 3.1%. So the true prevalence is going to be somewhere less than 5%. Now, these patients, some of them do respond to PD-1 inhibitors, and the chance of a PD-1 inhibitor working in an MMR prostate cancer patient is significantly higher than the unselected patient. But what I'm showing here is a so-called swimmer's plot of these responses in 11 consecutive patients from Memorial Sloan Kettering with mismatch repair deficient prostate cancer. And I'm not sure if you can see my cursor, but only 2 of these 11 patients have a response that lasts more than a year. So even though these patients may respond because of their mismatch repair deficiency, oftentimes these responses are transient and short-lived. And even in this molecular subset, which is only 3% of the total, the chance of a durable long-term remission with a PD-1 inhibitor is also quite modest and quite sobering. Now, these mismatch repair mutations are enriched in patients with high Gleason grade. We published a study a few years ago that showed that the overall prevalence in our hands was about 1%, but in those that have Gleason grade 5, or which is Gleason pattern 5+4 or 5+5, that is, we see an 8% prevalence. So there could be enrichment in the high Gleason scores, and there does appear to be some enrichment in metastatic disease compared to localized disease, but again, it's still a relatively low prevalence. One of the things that we became interested in was the potential antigenicity of a mutation. In other words, can particular mutations in prostate cancer become more antigenic than others? And one of our hypotheses was that a missense mutation, as shown in the figure on the top left, will only change one amino acid in the protein, whereas a frameshift mutation will change all the downstream amino acids that occur after the nucleotide insertion or deletion, resulting in the frameshift. And we hypothesized that patients with prostate cancer that have a mismatch repair deficiency, who have a lot of these frameshift mutations as opposed to missense mutations, these might create more antigens and therefore might respond better to a PD-1 inhibitor. And this is actually what we found in a small series of about 21 patients. Again, these were all patients who had a mismatch repair deficiency, and we simply asked the question, what's a better prognostic marker, the total mutational burden called TMB, or should we be focusing more specifically on these frameshift mutations, which are theoretically more antigenic? And when we separated the cohort above and below the median for overall mutation burden, there was a slight improvement in outcomes in the high tumor mutation patients. But when we looked at specifically frameshift mutations, which we think are more antigenic, in fact, the hypothesis was true that those patients have better outcomes. And then the final gene that I want to talk about, which might be a PD-1 sensitivity gene, is this gene called CDK12. Prostate cancers with CDK12 mutations comprise about 7% of cases. When these mutations are present, the cancer is defined by these focal tandem duplications that result in genomic instability. And these duplications, when they occur within exons, they can also result in antigens. So we have looked at a series of CDK12 mutant prostate cancer and PD-1 inhibitors, and we show that, again, there seems to be a slight higher response to these PD-1 inhibitors in patients who have these CDK12 mutations compared to the overall population. So I've put together the Antonarakis list of what I think is going to be the molecular marker of sensitivity to PD-1 agents. When you add these all up, you still only get to about 15 or 20% of all prostate cancer patients, but at least we're beginning to define some of the clues, and I've listed them here. I did not talk about the Pol E or Pol D1 mutations or the PDL1 3' untranslated region mutations, but these are quite rare. But the last bullet point is very important. It does not appear that PDL1 protein or immunohistochemistry or transcript analysis is prognostic for responses to anti-PD-1 as it is in other cancer types. Now, I want to leave you guys with some hope, because there is hope with immunotherapy. There were 2 things that were first presented in 2020 that really grabbed my attention. The first is a drug targeting a different immune checkpoint called B7-H3. Now, what some of you may know, or perhaps you don't, is that PDL1, which is the ligand for PD-1, used to be called B7H1. And B7H3 is sometimes also called PDL3. So it's in the same family. And a company called Macrogenics has developed an antibody drug conjugate targeting B7-H3. The reason why this is exciting is that PD-L1 is actually only expressed, it seems, on about 5 to 10% of metastatic prostate cancer. So perhaps we were barking up the wrong tree by looking at PD-1 inhibitors, where in fact the target for PD-1 is just simply not present in the majority of prostate cancers. This checkpoint, B7-H3, is in fact present in about 80 to 85% of prostate cancers. The data that I'm showing here is from a large phase 1 study of multiple cancer types. There were 7 patients with mCRPC in this study, and the 5 patients that I'm showing here, 5 out of 7, had at least PSA and sometimes objective responses. Yes, this is anecdotal. It's only 7 patients, but a 5 out of 7 response rate, and you can see the graph on the right. These were not wimpy PSA responses. They were very real PSA responses. This is now leading to a phase 2 study that we are leading here at Johns Hopkins, and other sites are participating in. And this is one of the exciting avenues that I would like people to keep their eye on. The second is this concept of using a bispecific T-cell engager. A bispecific T-cell engager is an antibody construct with 2 ends. One end binds a cancer target, in this case PSMA, prostate-specific membrane antigen, and the other end binds an immunological target, in this case CD3, which is of course present in the anti-tumor immune cells, the T cells. Amgen 160 is an intravenous PSMA targeting BiTE, bispecific T-cell engager. And this really caught many of us, including myself, by surprise. In the phase 1 study, there was a very high level of activity with a 34% confirmed PSA 50 response rate. But in addition to that, a number of patients were seen to have objective tumor responses, including for example, in liver metastases, which are very refractory to treatment. And in an unprecedented move, Amgen is proceeding directly from this phase 1 study into a randomized phase 3 trial, which will be opening later in 2021. And this is a very exciting compound. And of course, the advent of PSMA PET scanning, which was recently FDA approved, as many of you know, in UCLA and UCSF, will be very helpful in identifying patients because, of course, if the PSMA target is not present, then using a PSMA immunotherapy against it may not be as successful. But once again, something else to look out for in 2021 are these BiTEs. This is my concluding slide. I think that the future is here in terms of adopting not just a histological classification of prostate cancer, but also now a molecular classification. Here I have shown 5 molecular classifications that I have come up with. There are clearly others as well, and more to come. And the holy grail, in my opinion, will be to derive the molecular information from a tumor biopsy and from a germline DNA analysis, and then to do our best to tailor our systemic therapies against each of these 5 or more molecular subclasses of prostate cancer. And as I said on the title slide, I do think that the future is here. We are scratching the surface, but I think there's a lot more to learn with these molecular classifications. I'd like to thank you very much for your attention. And once again, Dr. Crawford, thank you very much for the kind invitation.
Thank you, Emmanuel. That was a really interesting and great presentation. A lot of data and a lot of hope. The things with BiTE are very interesting. One of the things you didn't talk about was PSMA lutetium.
Yeah.
I know that's different than immunotherapy, but what are your thoughts about the future of that now?
Yeah, I'm a believer. I think that it will work for the people that are very PSMA avid. I'm less convinced about the guy that has a lot of metastases and only 5% are PSMA positive. But people are talking about doing, let's say, a conventional PET scan and a PSMA PET, and then seeing how much concordance or discordance there is. And if there's a lot of concordance, it suggests that all of the cancer lesions, or the majority, are PSMA positive. If there's discordance, it suggests that the majority are not PSMA positive, but some are. I didn't want to get into that because I think there are better people to talk about, radioligands as they're called. Oliver Sartor being one of them, Scott Tagawa being another one. But I am excited. The VISION trial, which is the phase 3 trial of lutetium PSMA, they keep postponing their final top-line result date. They're now saying they're going to have top-line result in third quarter of 2021. Previously, they were saying first quarter of 2021. I don't know if that's a good thing or a bad thing. It might be a good thing because patients are living longer, so they're not meeting their endpoint. Yeah, I chose not to cover that here.
Okay, great. Let me just ask you one last question that people talk about a lot is, when should you do germline testing in men with prostate cancer? Just starting out, going even back to active surveillance. What are your trigger points to do that?
Right. So all metastatic patients, that's the easy part. In the localized or locally advanced patients, I think the current NCCN guidelines and perhaps the AUA guidelines as well recommend germline testing for anyone that has intermediate risk, high risk, or very high risk. Right now, in the absence of any family history of cancer or prostate cancer, my understanding is, at least as far as the NCCN guidelines are concerned, which I am part of, we are not currently recommending germline testing for the very low risk, so-called active surveillance population, with the exception of patients that have an Ashkenazi Jewish background, or patients that have a family history of prostate cancer in 2 or more relatives, or in patients who have a family history of early onset breast or ovarian cancers. So the short answer is, I don't think it is widely recommended yet for the active surveillance population. The study that was presented by Bal Carter and the Hopkins active surveillance team and Billy Isaacs, suggesting that the active surveillance patients that have BRCA2 or ATM germline mutations may in fact not be good candidates for active surveillance because they have a higher reclassification rate, progression rate. I have to tell you that on the NCCN panel, at least, there was a very fierce debate about that. And many of the urologists on that panel, who I will not mention by name, did not believe that we had sufficient data to recommend germline testing for active surveillance patients, meaning that even a germline BRCA2 or ATM positive patient who was in the active surveillance program, that we didn't have good enough evidence that they shouldn't be in one.
Okay, great. Thanks for summarizing that. Again, Emmanuel, thanks for taking time from your busy schedule to deliver this platinum lecture. The listeners to Grand Rounds in Urology are going to really appreciate this, and hope to see you around someday soon when we start having live meetings again.
Thanks very much. It was a pleasure. Thanks for the invitation.
Thank you.